I brought one. I brought one of the mannequins, but let's just go ahead and just finish this up, and the next time we meet, we'll go ahead and bring the mannequin again. It's just to practice the airway management. So let's see. Yeah, where are we? So again, we're gonna finish, which is chapter 10, and we're gonna start chapter 11 and finish chapter 11, and then from there, I'll send off your assignments. Did y'all were y'all able to get the what do you call it? I think it's chapter 11. I mean, the first part of chapter 10's uh video.
Yeah.
Okay, there we go. So anyway, so we stayed on techniques for artificial ventilation. And the techniques that we talked about, and this is something that we had just talked about too. I believe it's continuous positive airway pressure, which is CPAP. And the CPAP improves ventilation and oxygenation. CPAP can also help avoid the need for endotracheal intubation, which is an advanced level airway management. And oxygen should be titrated to the patient's SpO2 reading. So how do you titrate? How do you guys titrate, or how would you titrate the CPAP on a patient? What devices do you have out there, or what can you do to find out if oxygenation is actually happening?
Check their pulse oximeter.
Yeah, pulse oximeter is one of the best ones. I mean, it's a toy, but the way I see it, if you notice that the patient is getting better, then you maintain the treatment that you have, or you lower the treatment that you have, depending on if the patient actually starts getting worse or better. Oxygen should also be titrated. Continuous positive pressure. Positive pressure is measured in centimeters of water, or H2O. Positive pressure helps inflate collapse alveolar wall. So what they do is they actually force air in to actually expand the alveoli. Remember, all the airways that we have are actually encapsulated by the inner lining of the what do you call it, of the lungs, which is actually covered by mucus. So it'll help it actually expand. We have a couple of other chemicals that actually do get released, so we can actually get rid of that what do you call it, that stickiness. Okay. So it also decreases the risk of the risk decreases the work of breathing, and it helps displace fluid in alveolar and left ventricular failure. So basically what it does, it kind of pushes the water out. Remember oncotic pressure and hydrostatic pressure? How they actually work by, whether the pressure is greater inside the blood vessels, it kind of pushes water outside and whatsoever. That's part of the way it kind of works. Techniques in artificial ventilation, you have continuous positive, the continuous positive airway pressure, which is also known as CPAP, and delivered at 2 to 20 centimeters of H2O. But most orders do not exceed 10 centimeters of H2O. Begin at the lowest and titrate it up until you get a good oxygenation by looking at the patient's overall what do you call it, overall appearance, if they're not cyanotic anymore, or you can also use the pulse oximeter. There's another device that you use, but the problem is that this one is used whenever you actually have the patient intubated, and you're not measuring the amount of oxygen that is being put in, but the amount of oxygen that is being used. So we know that, let's see, if somebody's actually breathing normal ambient air, we take in 21%. How much oxygen do we actually use? good 5% más o menos. So we have like 16% oxygen left. So there's a device that checks to see if you actually have CO2 being produced, because if you use oxygen, you're gonna have CO2 being produced and it's gonna be pushed out. Okay. And continuous positive pressure ventilation, CPAP, criteria and indications for CPAP. That the patient should be awake and can obey commands, can maintain his airway, breathing with a respiratory rate of 25, or greater than 25 per minute, and moderate to severe respiratory distress or early respiratory failure. Indications include congestive heart failure. Now, do you guys remember what congestive heart failure is? Congestive.
Heart failure.
Basically, is the heart not able to pump out the blood as fast?
Yeah, isn't it having yeah, it's having an excessive amount of blood, so it's not able to pump sufficiently, right? It's like getting blown up like a balloon.
Yeah, and what happens is normally, you know, the older generations, the older people usually have what we call an enlarged heart or cardiomegaly, and that kind of pushes the heart to be bigger in size. But the issue is when it's bigger in size, it doesn't contract. And if it doesn't contract, it doesn't push the blood out as much as it should be. So the other one will be pulmonary edema, which is fluid in the lungs, COPD, which remember what three main diseases are or respiratory diseases are part of the COPD family.
Asthma, bronchitis, and emphysema.
There you go. So then we have asthma also and pneumonia. Contraindications, in other words, the reason you don't want to use a CPAP would be should not be used with caution, well, should be used with caution in patients with hypotension or hypovolemia. In other words, low blood pressure or low fluid levels in the body. Now, how can you tell if a person is hypotensive? How can you tell if somebody has low blood pressure? Huh?
Their ankles start to swell.
Think easier. How about taking the blood pressure?
Oh, yeah, you do that too.
Yeah, you can do it. How about hypoperfusion or yeah. How can you tell somebody is hypoperfused that they don't have enough fluid in their system?
You could do the skin pinch test.
Yeah, it's called the tent test. You can do that. You can see if their eyes are sunken. The other things that you can actually check is you can actually check if the patient what do you call it? Has that overall ill looking, you can check for a pulse, and if it feels thready, okay, that could be that they actually might be hyperperfused, in other words, they don't have enough fluid. The other one would be again the tent test, which is an easy one, or their skin is dry. You know, sometimes their skin just gets dried up. Administration procedures. Inform and coach the patient on how to actually breathe. Minimize the patient's anxiety. Remember that the CPAP itself is the device that goes on your nose and around your mouth, and it's tightened up pretty tight so where you can have a good seal. So with that one, you know, just talking about setting that one up, I mean, it might actually cause somebody to actually be anxious about it, because as it is, they're having problems breathing, and now you're putting something on their face that's going to prevent them from getting any oxygen. Obtain vital signs and the SpO2 levels, have an adequate oxygen supply, and place a patient in a seated position or semi-Fowler's position. Now, why would you put a patient in a seated position or semi-Fowler's?
to straighten up, like to keep their airway straight.
Yeah, well, not only that, you know, if you have fluid in your lungs, if you sit them up, the fluid goes to the bottom part of the lungs instead of being spread out equally in the lungs themselves. So that could be one of them. It's called what we call the position of comfort. Now, I know that you guys work on transfers. Which is the most common way of transferring a patient? Semi-foulers.
Let's see. Uh,
Okay, CPAP administration procedure. Assemble and check the device. Secure the mask with straps. Okay, increase pressure in increments of 2 centimeters of H2O. Basically, what you do is you set it up at 2, and you check the pulse oximeter within a few minutes. And if it's not going up, you crank it up 2 more until you get the desired pulse oximetry. Now, what's the desired pulse oximeter reading that you want?
98 or 97.
Yeah, anything above 95%, you're good. But I'll go for 100. But then again, it's like me wanting to play the lottery every single day and I never win. So you go anything above 95. And then continue to coach the patient. Assessing the patient's response to the CPAP. Check for respiratory and heart rates, a systolic blood pressure, oxygen saturation, end-tidal CO2. Now, the end-tidal CO2, remember I told you that in certain devices, now in this one, it's going to be kind of hard because normally the end-tidal CO2 is used when somebody's intubated. But there's a little device that's about maybe so big, okay? And it gets attached to the tube. And whenever you breathe out, it's checking the amount of CO2 that you're breathing out. So it gives it a specific color. It's either going to turn yellow or purple. Okay. Now, of course, if you have one of these monitors that has everything, then they'll tell you the number right then and there through capnography. And check to see if they're still complaining of difficulty breathing. Excuse me. Okay. Continuous positive airway, or also as a CPAP. Okay. Assessing the patient's response to CPAP. Monitor to make sure that this doesn't happen. A pneumothorax. Now, what is a pneumothorax?
The collapsed lung.
A collapsed lung, right? They're not telling you it's tensive. They're just telling you that the lung is collapsed. Gastric distension. Now, what is gastric distension?
When there's air inside of the stomach.
Yeah, when air accidentally goes inside the stomach, and the reason that happens is because you're blowing air into the airway, and sometimes you'll just get a little bit of air in the stomach. Increased respiratory distress or failure. Now all this means is that if they're getting worse, or decreased mental status if they go unconscious, or intolerance to the device. Some people will start tearing the device off their face. You'd be surprised. I've had patients that will take off the nasal cannula because they can't tolerate it. And that's something I would put because I know they're not going to tolerate the non-rebreather mask. Techniques in ventilation, of artificial ventilation. Okay, we have a bi-level or biphasic positive airway pressure, also known as a BiPAP. It's like the CPAP, but it allows you to set different airway pressures for inspiration and expiration. So you control how much air is going in and you control how much air is actually going out. Hazards of overinflation. This actually leads to serious complications like in cardiac arrest. Perfusion is actually decreased. In spontaneous breathing patients, return to left ventricle can be reduced only because you overinflated. Okay. Patients with a stoma or tracheostomy, and you're more than sure you carried these patients before. Remember, it's a tube that actually goes into the trachea through an outside hole, which is right around the cricoid thyroid area, okay, right in between. A stoma may actually indicate a tracheostomy, which actually mean may be temporary or they're permanently. A tracheostomy tube may be placed in the stoma. Stoma also may actually indicate a partial or total I'm sorry, laryngectomy. I'm sorry, I don't know how I can't read this. So laryngectomy is a complete removal because of some type of cancer or some type of issue. Okay. So this is a patient with a tracheostomy, and they actually just have a hole there, and they're actually breathing in without the tube itself. And you can actually put a tube there, or you can make that opening with a scalpel and actually put a tube in there. So you can actually have the patient actually breathe better. And what you get to see here is a diagram. Is a diagram of of how the stoma actually fits. So you have the opening, go straight into the trachea. Some of them will actually have a balloon, some of them won't have a balloon. I've seen some that basically have a complete removal of it, so they don't have a voice box, so they can't make any sound. Unless they have the little device that vibrates. Okay. Considerations. Or special considerations in airway management and ventilation. Okay, a patient with a stoma or tracheostomy to bag valve mask to tracheostomy tube. And actually what they're talking about is you get a BBM, and that opening at the BBM where the face mask goes will fit snugly on the tracheostomy tube. So all these devices are made so they can actually connect. And I know in one of the cases, if you decide to put him on the ventilator, or at the hospital to put him on a ventilator, the ventilator itself will actually fit perfectly into that. So it's a 50-millimeter port, so you can use all these airway devices, then will actually fit into the stoma or the endotracheal tube or whatsoever. So if there's not a tracheostomy tube, place a mask over the stoma and provide bag valve ventilation. So basically, a lot of people, what they do, instead of getting a normal size adult face mask, they'll get the pediatric one. And that one will fit right on top of the stoma itself. And chances are you're probably gonna have to suction before. So this is a diagram or a picture of somebody actually connecting the BBM straight to the stoma itself. A patient with a stoma or tracheostomy tube, bag valve mask to stoma ventilations, it may actually be necessary to actually suction the stoma before, because you might actually start developing mucus secretions because of an infection or whatsoever. It may actually be necessary to actually seal the mouth and nose so you can actually have a straight airway. I mean, the oxygen doesn't go the opposite way, or it doesn't retrograde back into the oral cavity. Okay, mouth to stoma ventilation, not recommended because of it exposes the EMT to respiratory secretions or droplet is actually using a face mask. The ones that you actually breathe into it. You must use a barrier device over the stoma between the before you perform mouth to stoma ventilations. Now, if you have a tube there, then you can actually connect it to that little tube that they give you when you're taking your CPR class that goes on the mask. It'll fit snugly there too. And that one has a slight barrier to it. Infants and children, place the head in a neutral position. Remember, how do we set up a child to be set up in a neutral position? You put towels on the back of the shoulders so the head falls a little bit back. Avoid excessive volumes and pressures. Use BBM with 450 to 500 mLs volumes and without a pop-off valve. Or yeah, use a oropharyngeal or oral nasal. I mean, oropharyngeal or I'm sorry, nasopharyngeal. There's not a separation there, so I can't read. A nasopharyngeal airway, if it's required, and ventilate at 12 to 20 respirations per minute, or once every 3 to 5 seconds, depending on how you actually want to work it. If you want to put the music, well, no, you can't because that's for chest compressions. Patients with facial fractures. You might actually have a patient that might have actually been in trauma, which normally EMS, that's basically what we do. We deal with trauma. Swelling can actually occlude the airway. Use an airway adjunct if needed. Avoid a nasopharyngeal airway. A patient with a mid-face trauma or bleeding may actually require frequent suctioning. You may actually have a foreign body obstruction or airway obstruction. If the patient is effectively moving air in and out, instruct him to actually cough and administer O2. Coughing will actually displace any airway obstruction that might be partially. If air exchange is poor, manage as for a complete airway obstruction. For a child or adult, perform abdominal thrusts. For an infant, perform chest thrust and back blows. This is all from your CPR class. If they actually have dental appliances, manage and place when the dentures are secure. If dentures are loose, remove them, put them in a safe place, and ventilate the patient. Now, oxygen therapy. Okay, 100% oxygen is stored in the cylinders that we have. And these are cylinders like the C size, the D size, the M size, or whatever, depending on what you guys carry. There's some smaller versions of that too. So the cylinder volume varies depending, but the pressure that you have inside the tanks in every single one should be at least 2,000 when it's not used. Okay. Duration of flow. The only way to actually truly determine how long this is going to last you, the oxygen in tank, it depends on how much you're actually going to give and how much you actually have and the size of the tank. And there's actually, believe it or not, a calculation. So if you thought that you weren't going to deal with math, nope, you're going to have to deal with math. You don't have to get a calculator out. But basically, there's a formula to calculate the tank duration. And it used to be taught a long time ago. When I took the class, when I took my basic level, we were taught this. But then after that, they stopped teaching it. And I don't know why. But I mean, it's something, the only thing you do have to memorize is, or if anything, carry this little paper that has D equals to 0.16, G equals to 2.41, E equals to 0.28, H equals to 214, and whatsoever, right? So you memorize that or carry it there so you can actually calculate it. You're going to be doing a transfer, let's say from here to San Antonio, and the person needs to be in oxygen. Make sure that you have enough oxygen in your tank itself, which should be your large tanks. It could be an H tank, it could be a G tank, or it could be a K tank, depending. And then make sure that you have those portable ones just in case you run out. Now, if you run out of oxygen, do you panic?
Yes.
Why would you panic?
No, I'm just kidding. No.
So, no. You said you're going to panic. Why would you panic? You have 21% of air and ambient, 21% oxygen and ambient air. So you can actually give them ambient air if you run out. Don't freak out. And it's better than zero. Simple as that. Okay, this is the calculation that we talk about. Okay, and basically as an example to determine how long the full 2000 psi e-cylinders will actually last with a patient on a non-rebreather mask at 15 liters per minute. And normally, non-rebreather mask, we actually go up to 15 liters per minute. So we're talking about a size E tank. And remember that little number that you have to memorize? So basically, you have to get 2,000, which is the amount of pressure that's inside the tank that you should have inside the tank. Now, let's say if you crank it open and you find out that you only have 1,500, then you put 1,500. Okay, that depends on the amount of air that you might actually have inside the tank or the pressure. Now, you always have to subtract 200. 200 is your safe residual volume. Once the tank gets to 200, the pressure is not there to actually expel the oxygen out of the tank. So you have to have that safety measure right there. So it'll be minus 200. So let's see if it's 2000 to minus 200, you have 1800 that you can use in the tank. And then you multiply this by 0.28, and 0.28 is that little number that we dealt with here. It's a size E tank. Okay. And then you divide that by the amount of liters that you put the paste in the non-rebreather mask at. So we put it at 10 liters per minute. This number 15 becomes 10. You understand? So once you calculate that out, it should tell you, it should be, like in this case, it should be 33 minutes and 6 seconds that oxygen tank is going to last you. So you might actually want to set up an alarm. Or if you have the non-rebreather mask and you put it on their face and you notice that he's not sucking the residual bag that's on the non-rebreather mask, or that little plastic bag that's attached to it, then you might be able to lower it to 10. And then of course have your pulse oximeter to find out if you're actually giving him ample amount of oxygen. It's not a hard calculation, guys. You don't need to have a calculator. And if you do, ay, trágame tierra. Okay, safety precautions. Okay, no combustion material contacting the cylinder or actually any of its components. And what do you mean by combustible material? Well, fires. Duh. But guess what? There's another one that is referred to as petroleum products that will actually could start a fire in the tank itself. And a lot of times, Scotch tape or the tape that's in what do you call it? Duct tape. That gluey part is actually combustible material. So a lot of people say, well, you know something, I don't want it to get dirty. I'll wrap it around with tape. Well, the problem is once you turn it on, you're gonna have a fire. No smoking near oxygen cylinders. Usually you should store the cylinders below 125. Now, the way the temperature has been right now, you're safe right now because we haven't reached 125 yet. But give it a couple of more weeks. Okay, use with properly fitting a regulator, and what's the oxygen regulator. Keep all valves closed when not in use, and keep cylinders secured so they don't fall down. And do not place your body over the valve itself, because the pressure might be very, very high where you can actually inject yourself. I don't want to say the word inject, but air can actually be forced in into under the skin. I know it sounds kind of incredulous, but it could happen. Pressure regulations reduce the pressure of in the cylinder to a safe range and control the flow of oxygen. A therapy regulator delivers oxygen from 0.5 to actually 25 liters per minute. I mean, that's a big difference right there. We can use humidifiers also. Have y'all used a humidifier before?
Yes. Well, not at work, but I've used one before.
Well, actually, the humidifier that we're talking about is just a little canister of water that the oxygen goes in, and then whatever goes
Isn't
out.
a nebulizer considered a
You can actually work with a
humidifier?
nebulizer, but this one, and I hate to say it this way, resembles a bong. You guys know what a bong is, right?
No.
No, really.
Yeah.
So basically, and what they do is,
No, I know what it is. I'm just kidding.
When you smoke, let's say you're smoking a cigarette and you put it through a bong, you're getting that smoke moist and you breathe in moist. That's what all it does. I don't know. I don't remember if I have a picture of that here. Well, actually, I do. You have a container of fluid of water that's connected to the oxygen source. Now, the only bad thing with this one, guys, the only bad thing when you're using it inside an ambulance, is the ambulance ever still when you're driving? Because I mean, if you're moving all over the place, that water in there is swirling, and it might actually go down the tube and into the breathing device.
We do keep those. We have them in our
Yeah.
units.
Yeah, and and I hate to say this, but I mean, I've used them before. I just don't have them completely filled the way they come. I kind of spill some of it out, so it will have a harder time to actually get in, because oxygen from here goes down into this and mixes up with and the tube that's inside here and inside the water, and it goes out and it actually comes out humidified to the tube, the breathing tube. Okay, too much oxygen can actually worsen the condition, such as ischemic stroke or acute coronary syndrome. And all that means is that if you give a lot of oxygen to somebody, let's see, if somebody's having a heart attack, and it's because there's an occlusion in the blood vessel, and you're giving oxygen, well, that oxygenated blood is actually getting to the point where the obstruction is that's preventing any blood from going. So now that blood is actually getting concentrated oxygen, increasing the ratio of oxygen in there. And I know someone told me, and I mean, I don't think it's true, but somebody told me, said, no, you go from O2, which is oxygen, to O3, which is ozone, which it doesn't happen. I don't think that happens. But what happens is that when you have too many oxygen molecules, you have what we call a release of an electron. Okay? And when that electron gets released, it causes damage to the tissue. So what happens is that you breathe, you're not breathing in, all of a sudden you decide, something. I remember for chest pains, we also give them aspirin and we give them nitro. So you give them those two medications. Nitro is either gonna dilate the blood vessel, so blood can actually flow through, and aspirin is gonna break that clot to where there's a clot there. It's gonna make it smaller and it's gonna get oxygen to go through. Now, the only issue again with this one is that you already have a high concentration of O2 over here on the backside, and now it gets released, and it releases these things called free radicals. And free radicals are not good. I read I remember when I was in medical school, I read that when somebody smokes a cigarette, the reason they might actually get cancer is because you get the release of free radicals. And it ionizes the tissue and it causes it to mutate. Such patients should only receive oxygen if they have evidence of hypoxia or dyspnea or an SpO2 level lesser or less than 94%. Begin administration of 2 to 4 liters per minute by nasal cannula. Always follow your protocols. If your protocols say to go up to 6, you can go up to 6. Administer supplemental oxygen and maintain an SpO2 level at 94%. Dyspnea or respiratory distress, signs of poor perfusion, or signs of heart failure itself. Indications for oxygen administration: cardiac or respiratory arrest, any patient receiving positive pressure ventilation, signs of hypoxia and adequate respirations, and SpO2 of less than 94%. Indications of oxygen administration: any medical condition that may actually cause hypoxia. An SpO2 level reading of 94% or less, or if the level that saturation is not known. Dyspnea or respiratory distress, signs of poor perfusion, signs of heart failure, and suspected shock. Special considerations, medical condition of the patient, trauma condition of the patient. If they're pregnant, the patient less than 20 weeks of gestation. Also, inhaled poisonings or toxic exposure, or chronic obstructive pulmonary diseases. Okay, hazards. Oxygen toxicity is rare, but can actually happen over long periods of time. Manage or damage to the retina can actually occur in premature babies, and that's retinopathy of the infant. Respiratory depression may actually cause some COPD patients, Okay, click on the condition that actually is not an indication for administration of supplemental oxygen. Acute coronary syndrome with an SpO2 level of 95%. Severe bleeding with altered mental status. Dyspnea with SpO2 level of 90%. A patient with a stab wound to the chest. So where wouldn't you give oxygen?
With an acute coronary syndrome with this blood saturation of 95%.
Yeah, because the saturation is 95%, which is still within normal range. Oxygen administration procedures. Ensure that the the cylinder contains oxygen. Open and shut the valve for 1 second so you can get rid of any debris that might be in there. Place the yoke of the regulator over the valve and actually tighten it. Open the valve, half turn to check the pressure, attach the tubing to the regulator, set the flow rate depending on what you want to have at 10, 12, 15, whatever, and apply the device to the patient. Initial oxygen administration. In this case, what you get to see is a regulator. And the regulator itself, I don't know if you're gonna be able to see this. Let me see. Yeah, you get to see the regulator right here. I'm sorry, this is not a regulator. This is the oxygen tank. They have the neck of the oxygen tank. And this is a protective cover that whenever you get your oxygen tanks refilled, they put this protective cover so no dust or debris goes in there. Crack open the oxygen tank so you can get rid of any debris within this little hole right there. Put the device, which is a regulator itself, and remember in the regulator, there's an O-ring right here. Okay, that sometimes people forget to check for. Tighten it up, finger tight. And this is when you basically crank it open again to see how much you have. Now, how much does it have right here?
2,000.
2,000. Well, look, yeah, it's about 2,000. Okay, and look at this right over here. You get to about 500 and they're already telling you to refill it. That's a safe residual volume. So at this point, you attach the device. You crank it to whatever level you want to. And at this point, you have, in this situation, well, it's at 0 right here, but you crank it open, let's say to 15. Okay, now at this point, this is a non-rebreather mask. How can you tell this is a non-rebreather mask? It's got a reservoir bag, and it should have one valve here and another one here. If it only has one, it's a partial non-rebreather mask. If it's got two, it's a full non-rebreather mask.
But I thought that one was a partial because it's open. I
It
thought
is,
they both had to be
no, it is a
closed.
partial, because there's one side open. And what you do is you make sure that this bag fills up first. So ideally, there's another valve right here that he's pressing down on, so the oxygen that's coming in from the tank is not going out, but it's going inside the bag. Now, I've seen patients when we put this device on them, the non-rebreather or the partial non-rebreather, they suck that oxygen from that bag. So you need to increase the amount of oxygen you want to put in there. You put the non-rebreather mask. Remember, it's got an apex section that goes to the bridge of the nose. And then you basically determine if the oxygen is working. Now, in order for you to terminate oxygen therapy, when terminating oxygen therapy, first remove the mask from the patient and then turn off everything and disconnect. And it makes sense because you're still providing oxygen. You don't want to turn it off and then go and remove the mask because you're not giving him oxygen. Just remove the mask and then he's breathing at 21%. Transferring oxygen source portable to onboard. When administering, I'm sorry, when transferring from one oxygen source to another, first remove the mask from the patient before turning the oxygen or disconnecting the oxygen tubing.
You only have to do that with the BVM, or I mean, a non-rebreather or rebreather, right? Because the nasal cannula, the patient can just still breathe ambient air.
Yeah, you can. I mean, I would just do it with every single one. You can use it with a simple face mask, or you can use it with the nasal cannula, just so you can get used to doing it. Okay, a non-rebreather mask is used to deliver high concentrations of oxygen. The flow rate usually is about 15 liters per minute, and always keep the reservoir bag inflated. And then here, I can't tell if she has a non-rebreather mask. No, it's got the same partial non-rebreather. He only has a valve on one side. Okay. And basically, this reservoir is used to actually get 100% oxygen. And when you don't have one, then the amount of oxygen is going into the person that's breathing is going to be a lot lower, because now you're mixing it up. Since you don't have a valve on one side, you're mixing it up with the ambient air. Excuse me. Okay. Nasal cannula. A nasal cannula is used to deliver lower concentrations of oxygen. The flow rate is usually 1 liter per minute to 6 liters per minute, max 6. The nasal cannula basically is just two little tubes that go inside your nostril, but it's actually being mixed up with ambient air. And if you're mouth breathing, then you lowering the concentration. Other oxygen delivery devices, you have a simple face mask, partial non-rebreather mask, tracheostomy mask, and Venturi mask. This is a simple face mask. The difference is that this one here does not have the reservoir. I didn't notice that. This is a partial non-rebreather mask. Remember, we would have both of them. Then it would be a full non-rebreather mask. This is a CPAP device. Well, no, I'm sorry, it's a Venturi mask. I'm sorry. In the Venturi mask, all it is air is going in and it actually accelerates it to get into the patient so it can go deeper. Okay. Okay, so we'll just go ahead and continue with the next chapter. So, yeah, we can shut this down. The next chapter that we play with is gonna be, where is it? I don't have it. Hold on. I have it somewhere. I just can't find it. Okay, let me just shut this down. Let me see if we can actually get into this. Oh, sorry. Now I know what I was doing wrong. Chapter 11, the next chapter, which is chapter on vital signs. Yeah, it's not what's showing up here. So give me a few seconds, guys. I lost the chapter again. This it? No, this is not it. Okay, there you go. For whatever, I just don't know why what this happened. Okay, there you go. Now we can see it. Now, chapter 11 is about your basic vital signs. You guys are still there, right?
Yes, sir.
Okay.
Yeah.
So basically, baseline vital signs, monitoring devices, and taking a history. This is kind of a simple chapter, guys. Because you've probably been doing this all this time. So basically, patient assessment is a skill that the EMT must provide for every patient. Patient's assessment helps you to actually find out what could be wrong with the patient and this makes you decide what care should be provided to the patient. Measuring vital signs over time reveals trends. So basically, all it's telling you is that sometimes if you take your vital signs enough times, it can actually tell you whether the patient is doing better or doing worse. Okay, patient history helps you to understand the underlying problems that the patient might actually be having too. So gathering patient information. When you arrive at the scene of an emergency call, you must gather information about the patient's condition. Some information is readily available. Other information takes detective work so you can actually figure out what's wrong with the patient. Now, and by detective work is you actually need to know exactly what I might actually be what might be actually the symptoms that the patient is showing, what they actually mean. And you know some of them already. But like an asthmatic patient, what, you have an asthmatic patient, how can you tell he's an asthmatic patient?
Wheezing sounds.
Yeah, wheezing sounds, respiratory distress, the look of that impending doom on the patient's face, all good signs of asthma. Or he might actually have a little bracelet that says asthma. Your vital signs are outward clues about what it might actually be happening to the patient. So, or happening in the body, that include respirations, pulse, skin, pupils, blood pressure, and pulse oximetry. You take baseline vital signs are the first set of measurement that is taken, and that's what you're going to compare every other vital sign that you're going to be taking. Later findings and findings are compared to baseline vital signs, and they usually detect the trends. Some vital signs are detected by looking, listening, and feeling. Other vital signs are actually measured by special equipment. Respiratory rate for adults, it should be 12 to 20 breaths per minute. Respiratory rates that are less than 8 or greater than 24 are of concern to us. Interpret findings based on patients' overall presentation. So this guy, what he's doing is he's actually timing the respirations, and he's concentrating with the other hand to see if the chest falls and rises or falls.
Sir, I don't know if we're supposed to be seeing like a different slide in the presentation, but we've been stuck on like the first slide where it says chapter 11 baseline vitals.
Okay, let me. I don't know why. Sometimes it happens. I don't know why. Can you see that?
Yeah, I see it now.
Okay. So basically, assess the breathing, and this guy is basically just has his hand over the chest, so you can actually feel if it's going up or down. And here you have normal respiratory rates for different age groups. So for adults, it's 12 to 20. For adolescents, 12 to 15 years of age, it's 12 to 20. School age children, which is 18 to 25. What? Oh, sorry. School age children, 6 to 11. Respiration should be 18 to 25. Preschoolers are 3 to 5 years of age, 20 to 28. Toddlers, 1 to 2 years of age, 22 to 37. Infants, less than a year of age, 30 to 53. And neonate births, and it's up to 1 month, 40 to 60 breaths per minute. So we check for the respiratory rate, ventilations, an adult patient breathing at a rate greater than 40 per minute, or an infant. Hold on, I think. An infant or young child breathing at a rate of greater than 60 per minute. Fatigue usually occurs at this, and the rate actually cannot be maintained, and the rate is too fast to allow adequate oxygenation anyway. So quality, what you're going to be defining for quality is going to be normal, shallow, labored, or noisy. Okay. Respiratory rhythm is the regularity or the irregularity of the respirations. Respiratory rhythm. We have different breathing patterns. One of them is called Cheyenne-Stokes. We have Biot's respirations, apneustic respirations, agonal respiration, Kussmaul respirations, and central neurological hyperventilation. So sounds that we hear when we're dealing with noisy breathing. Snoring, which could actually be defined by the tongue. Uh, by the tongue or partially obstructing the upper airway or the level of pharynx gurgling. If there's any type of fluid in there, stridor, partial obstruction of the upper airway at the level of the larynx itself. Sounds that you can actually hear with a stethoscope: wheezing, constricted narrowing, and inflammation, reducing the internal diameter of the bronchioles or the lung itself. Crackles is fluid surrounding and filling up the alveoli, and rhonchi is mucus is actually blocking and you're getting air through the mucus. Pulse, the location of the pulse that we have. Pressure wave generated by a contraction of the ventricle itself. Remember, it feels like a little ball that's actually traveling through there. You have it directly reflects the heart function to see if it's actually pumping out. Location of pulses, you have the carotid, which is in the neck, femoral, which is in between the legs, brachial, which is under the arm, popliteal, which is behind the knee, posterior tibial, which is on the side of the tibia, and dorsalis pedis, which is right on top of the foot itself. Now, if the patient is 1 year or older, check radial pulse. 1 year or older without a peripheral pulse, check for carotid pulse. Less than 1 year, check for brachial pulse. Assessing the pulse and quality and rhythm. Now, what this person is, they're checking the pulse, and they can easily check respirations at this time too. And because their hand is right next to their chest. But you check it for a whole minute, half a minute and multiply it by 2, or 15 seconds and multiply it by 4. On a kid, this is where the brachial pulse is actually found. Okay, it says a carotid pulse, which is right around the neck. I went crazy, sorry. Excuse me. Heart rate. So this is basically assessing the carotid pulse itself. Heart rate for adults, the average range should be 60 to 180 beats per minute. When they're resting, infants should be a little bit higher than that, or faster than that. I'm sorry. Tachycardia is a heart rate of anything above 100, and bradycardia is anything below 60. Interpret findings based on the patient's overall presentation. So what is it that they're showing you, or how do they look? Now, pulse rates by age groups: adults 60 to 100, adolescents 60 to 100, school-age children 6 to 11 years of age is 75 to 118. Preschooler 3 to 5 years of age, 80 to 120. Toddler 1 to 2 years of age, 98 to 140. Infant 1 month to 1 year is 100 to 180, and neonate from birth to 1 month should be 100 to 205. Man, it's warm. Is it cool where you guys are at?
Yes, sir.
Because it's not here. Okay, heart rate. To obtain the heart rate, palpate the pulse with 2 fingers. The tip of the 2 or 3 fingers. You can count the beats for 30 seconds and multiply it by 2. Pulse quality and rhythm. Remember to record the pulse quality if it feels strong, like bounding, like boom, 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 boom. Weak, regular, or irregular. Now, when it comes to regular, irregular, we're talking about the rhythm itself. Now, the findings and what they might actually mean. Rapid, regular, and full. Exertion, in other words, exercising, fright, fever, high blood pressure, or very early stages of blood loss. Rapid, regular, or thready. Once it starts feeling thready or it's barely going through it, it's a reliable sign of shock, often evident in early stages of shock. If it's slow, then you might actually have head injury. Now, remember, when we're dealing with head injuries or increased intracranial pressure, your pulse goes down and your blood pressure goes up. Now, when it's shock, your blood pressure goes down, but your pulse goes up to compensate. So that's how you can actually tell that the patient is actually has some type of head trauma. So if it's slow as head injury, barbiturates, narcotic use, some poisons, possible cardiac problem, or actually other medication or medical conditions such as hypothyroidism. The pulse, cardiac arrest, no pulse. My patient might actually be in cardiac arrest, or you don't know how to take a pulse. What click on the heart rate that it works, that would be outside of normal and range for an 8-year-old child. Oh, wait a second, they're telling us that this guy is an 8-year-old child, so what would be considered abnormal? So let's go to that little diagram. And it was breaking down the pulse by age groups.
Wait, what was the age?
Eight-year-old.
8-year-old.
Yeah.
The 56 beats per minute, no?
Could be.
No, no. Oh yeah.
Yeah. It's 1 to 2. It's 6 to 11. It should be 75 to 118. 75 to 118. So all 76 is up there. 116 and 120, so it's 56 beats per minute.
130 is also high. Isn't it high for a 8-year-old?
130.
Yeah.
Yeah. That's not fair. They gave us 2 abnormal. Anyway. So skin, it says the appearance and condition of the skin. Look for color, temperature, condition, or capillary refill. You check for temperature also with the back part of your hand. And this is basically all this is capillary refill. You press and blanch the skin and let go. And within 2 seconds, it should be back to normal. Pink again. It turns white, it goes into pink. Check color. Check for color of the nail beds also. Oral mucosa and conjunctiva. Pink is normal. Paleness is pallor. Blue-gray is cyanosis. Red color is flushing. Yellow color is jaundice, and then of course you have your modeling. Remember I told you about modeling? How you can tell a person is going through modeling.
Uh, no, I don't remember it. Is it the clenched jaw?
No, modeling is whenever you have blotches of, just imagine the way a giraffe is. It's got all these little squares. If that is actually showing up in your skin, you're modeling and you're not doing good. Skin temperature. Lift the patient's shirt and place the back of your hand so you can check for the skin itself, the temperature of the skin. Hot may actually indicate fever or exposure to heat. Uh, cool away or cool may actually be a sign of inadequate circulation, shock, or exposure to cold. Cold indicates extreme exposure to cold. Skin conditions, you might actually have a moist skin, may actually indicate shock, poisoning, heat-related cardiac or diabetic emergency, or many other conditions. Skin that is both cool and moist is often described as clammy. Diaphoresis is the term used to describe profuse sweating, and skin that may actually be abnormally dry may actually be a sign of special or spinal injury or severe dehydration. I've been hearing that people are dying of heat related strokes or whatever in these past few days because of the way the heat is, and it's humid too. So pupils, when assessing the pupillary reaction, use only a pen light, not an extremely bright light. Check for pupils for size, quality, and reactivity to light. So in the top, you have constricted pupils. In the middle, you have dilated pupils. In the bottom, you actually have um, regular sex pupils, I'm sorry, or irregular, so one big and one small. So dilated pupils, cardiac arrest pupils will also be fixed. Drug use such as LSD, amphetamines, and cocaine. Now, guess what where amphetamines are actually found in, or most of them. It actually
Medication.
it's a medication that they give kids, Adderall, which basically is a form of amphetamine. The other one is diet pills, dude. So the patient has constricted nervous system disorders or narcotics. And around here, you think about narcotics, uh, unequal. They might have had a stroke, head injury, artificial eye. Now I got tricked by this one. I took the patient to the doctor, and I told him, hey, by the way, one of his pupils is not reactive. So he goes in there, gets my pen, and starts tapping the eye with a pen. And you can hear click, click, click. It was an artificial eye. That's why it wasn't reacting. Unequal stroke, head injury, artificial eye, occasionally a narrow, abnormal finding, eye drops, or trauma. Non-reactive, cardiac arrest, brain injury, eye drops, or drug intoxication or overdose. Blood pressure. Now, blood pressure is another set of vital signs that we check. Blood pressure is a force of blood against the arterial walls. And when I drew the drawing, I guess I don't have any English majors that I'm not getting corrected. Whatever pressure that gulp of blood is actually putting against the wall, such as systolic, whatever's left behind is your diastolic. Now, this is basically normal blood pressures by age groups. Adolescents 12, obviously, well, adult systolic blood pressure should be 120 or less, and diastolic should be 80 or less. Adolescents 110 to 131 should be systolic, and diastolic should be 64 to 83. Preschoolers, systolic should be 112 to 120, and diastolic should be 61 to 80. Preschoolers, which are 3 to 5 years of age, their systolic should be 89 to 112, and diastolic should be 46 to 72. Toddlers, 1 to 2 years of age, systolic is going to be 86 to 106, and diastolic is going to be 42 to 63. Infants, from 1 month to a year, their systolic should be 72 to 104. Diastolic should be 37 to 56. Of course, you have your neonate, which are 1 month, birth to 1 month, 67 to 84 diastolic, and 35 to 53 diastolic. Blood pressure indications or hypertension. Adults, any diastolic or systolic less than 90. Children, any systolic less than 90. Now, this is where you have to get a little bit smart about this. Children 1 to 10 years of age, 70 plus 2 times the years of age. So let's say if the kid is 8 years of age, well, you're going to multiply 2 times 8, it's going to be 16. Okay, so 70 plus 16, it'll be 96. 86, I'm sorry. I think I'm wrong. I suck at math. In infants, 1 to 2 years of age, anything less than 60. Blood pressure. The difference between the systolic blood pressure and the diastolic blood pressure is the pulse oximeter. Okay, pulse pressure should be between 25 and 50 percent of systolic blood pressure. And normally, go to the next one. Low blood pressure is an indicator of hypotension. High blood pressure is an indicator can damage the heart and actually the vessels. Take a blood pressure in all patients that are basically 3 years of age and higher. Methods of measuring blood pressure. There are 2 methods of measuring blood pressure with a sphygmomanometer. Remember, sphygmomanometer is your blood pressure cuff. Auscultation and listening to the systolic blood pressure, diastolic sounds through the stethoscope. Palpation is a feeling of for the return of the pulse, and the cuff is deflated. How did it actually do it? And normally they tell you to go ahead and put this about maybe an inch above the antecubital fossa. Oh, I lost it. Anyway, so the antecubital fossa is a little section when you bend your elbow, is that indentation that's up here. Tighten it. Then basically what they're doing is palpating the brachial artery. And the brachial is going to break down into the ulnar and radial. Close the little valve that's located here so you can actually inflate the cuff. Okay. Deflate the cuff. slowly. This is what normally it takes you a little bit of practice. Slowly, so you can actually be reading the numbers. Now this is palpated. You find the pulse and then you inflate up, and when it disappears, that's it. You're only gonna get one number. Okay, blood pressure. Testing orthostatic vital signs. And guys, you do this all the time, especially with transfer companies. You have the patient lying down, you sit him up, you take the blood pressure when he's lying down. Okay, and then you sit him up and you find out if there's a difference. If the heart goes up at 10 to 12 beats per minute higher, then they're positive or for orthostatic. If the blood pressure decreases, then you're still bleeding. Vital signs. If the patient is stable, vital signs should be taken and recorded every 15 minutes. If he's not stable, it's every 5 minutes. Okay, at this point, place the patient supine on the stretcher and take the blood pressure. Then stand him up and do the same thing. Let's see. Just trying to read this. Compare the readings when it's standing up and lying down. And the key thing is that when you compare the readings, an increase in heart rate 10 to 12, and a decrease in blood pressure 10 to 12. I mean 10 to 20. Guys. It's considered a positive orthostatic test. And in companies that do transfers, now you can actually what do you call it? You can actually justify why he needed an ambulance. Pulse oximetry detects detects hypoxia by measuring oxygen saturation levels in the blood hemoglobin. Normal SpO2 levels 97% to 100%. SpO2 level at 94 indicates hypoxia, and an SpO2 of lesser than 90 indicates severe hypoxia. And basically all you do is just put the pulse oximeter in the finger and wait till it starts giving you the reading. It can give you the pulse and the oxygenation. Indications for pulse oximetry. Apply whenever the patient is the oxygen status is a concern, or when hypoxia is suspected. The pulse oximetry or oximeter reading is a vital sign. It should be pulse oximetry reading is vital signs. It should be standard measure in patients, along with respirations, pulse, skin, pupils, and blood pressure. Monitoring concerns. Any limitations of the pulse oximeter. The problem is that the pulse oximeter, if it's very cold outside, it's not gonna work, because your body tends to constrict the capillary arteries, or the capillaries. I'm sorry. Okay. Any condition that interferes with the blood flowing to the area where the probe is attaching, or attached, may actually produce an erroneous reading. If the pulse rate shown on the pulse oximeter does not correspond, we'll actually with a patient actual rate, the pulse oximeter is also not accurately reading the blood flow and oxygen saturation. Limitations of pulse oximetry: whenever there's somebody in shock, then the pulse oximetry might not work. Hypothermia, in other words, when they're very cold, it might not work because one of the first things the body does is shuts down all the peripheries. Excessive patient movement, nail polish, and carbon monoxide exposure. Anemia. Now, hopefully you guys didn't get a carbon monoxide poisoning and then say something, yeah, he seems normal. When his pulse oximeter is abnormal, so. Oh, actually, the pulse oximeter might actually be normal because it goes by the hues of red. So you might actually have a patient that has a pulse oximeter on, but he's not cyanotic because he has a carbon monoxide poisoning. Monitoring equipment, non-invasive blood pressure monitor can actually be set to reassess the blood pressure at selective intervals, or can actually be activated manually. Alarms can actually signal pressure that actually exceeds the or fall below the set upper and lower limits. Procedures for non-invasive blood pressure monitoring. Explain the procedure to the patient. Always obtain the first blood pressure regarded by reading by auscultation. Okay, in other words, you're going to be using your stethoscope. Apply the and position the apply the position of a properly sized cuff. Activate the device and actually after the cuff deflates, use a systolic and diastolic blood pressure reading will actually be delayed. There's a bigger portion way. I mean, a big pulse oximeter tells you the same thing as the small ones. Might be a little bit more accurate. Capnometry, which is basically entitled CO2, and it's the one that I told you that it doesn't. It did tell you how much oxygen you're utilizing by determining how much carbon dioxide you're breathing out. It's not an invasive method measuring the levels of carbon dioxide. In the end, the exalted or exhaled air. Sorry, man, I can't. At the end of the exhaled air, EtCO2, the measurement sheet of the CO2 at the end of the expiration. So basically, you're checking to see how much oxygen you use by finding out how much carbon dioxide you still have. Okay, or you developed. Okay, the patient's pressure of CO2 in the arterial blood, capnometry, the measurement of expired CO2, the capnogram is a vital or virtual or visual recording of the CO2 waveform throughout the chase of breathing, or throughout the phases of breathing. And it kind of gets hard to explain away what happens. Just remember that it just checks your CO2 levels. The reading will actually decrease during the hyperventilation syndrome, and the reading will actually increase during hypoventilation. Okay. Reasons for EtCO2 changes. The reading will decrease with a decrease in cardiac output, blood flow or pulmonary capnography, perfusion, and decline in metabolic activity. The reading will actually increase in the with an important improvement in alveolar ventilation. Reasons why you have changes. A sudden increase in EtCO2 reading in the cardiac cycle, patients may actually indicate the patient has regained a pulse itself. EtCO2 is a level of to confirm the monitor if the monitor is correct, and the ventricular tube is placed and whatsoever. Reasons that for EtCO2 changes, EtCO2 is used to monitor the effectiveness of chest compressions. It decreases EtCO2 levels level, and actually reading usually indicates compression fatigue. Okay. Gain control of the scene, preparing for taking a history itself. And the history itself is, remember, sample, OPQRST, and whatsoever. These are questions you're gonna have to ask. Get control of the scene, achieve a smooth transition of care. You know, you have firefighters there, and actually they're trying to give you the patient so you can transport. You need to be control like this. I don't know. That's I can't remember what term it is. Okay. Reduce the patient's anxiety, bring order to the environment, introduce yourself, gain patient consent, position yourself, use communication skills, be courteous, and use touch when appropriate. Not everybody likes to be touched, guys. Maintain control, recognize when the scene is not safe to be or cannot be controlled, and do not jeopardize your own safety. If necessary, remove yourself and the patient from the scene. The history itself begins with the reason why the EMS was actually called, which is your chief complaint. The history helps you guide the examination. The process must actually be dynamic, and for situations, in other words, you just don't stay stagnant. You changing depending on what the patient is showing you. Get history from the patient if possible. After the chief complaint, determine the history of the and present the illness. Statistical and demographic information, date, time, patient's identity. The other thing that you might need to worry about and taking is current health status, or current medications they might be taking, or allergies they might actually be having, and whatsoever. Current health status, find out if they're taking any alcohol, drugs, and related substances, if they're in a diet recently. Recent screening tests, diet, immunizations, environmental hazards, use of safety equipment, and family history. Document the information the patient provides as accurately as possible, and type of questions. Open-ended questions can actually help or yield more information. Closed-ended questions are going to stop you from determining. Techniques in taking your history, active listening techniques. There's facilitation, reflection, clarification, and empathy. Confirmation and interpretation. Just remember something. A sample history, signs and symptoms, medications, allergies, pertinent past medical history, last oral intake, and events linked to that condition. Okay, then you use the mnemonic OPQRST, remember onset, provocation, palliation, uh, what's it, quality, radiation, severity, and time. And I think we've gone over these last year. Okay. Sensitive topics. When asking sensitive questions, remain non-judgmental, which with EMS, it's kind of hard to do. And ask questions that pertain to his directly to the medical history of the patient and patient care. Respect the patient's privacy. Ask appropriate time and location, and remain within the scope of practice. And don't do anything you didn't get trained for. Special challenges, if you have a silent patient, overly talkative patient also, patients with multiple symptoms, anxiety patients, anxious patients, angry patients, intoxicated patients, and crying patients. Okay, special challenges. Depressed patients also, confusing behavior or history, patient with limited intelligence, language barrier, hearing impairment, visual impairment, or talking with a friend or family. They're trying to give you all the information, but they're not helping. Okay, sensitive topics, special challenges, pediatric patients, and elderly patients. Okay, so let me see. Okay, so we're done with these chapters. So, do you guys have any questions?
No, sir.
No, sir.
Well, we'll call it a day. I don't know what time is it. Okay. And I'll post these up, and I'll post up the assignment for chapter 11 also. So just give me
Okay.
about an hour or so. Right? So I'll see you.
All right, sir. Good night.